Care Collaborative's national briefing on Do Medical Homes Work? We're going to be walking through our new evidence report on cost utilization and payment reform, and we are thrilled to have you join us. I have a few housekeeping items to begin with, and then we will jump into the report itself. The first housekeeping item, as many of you are well aware, is a webinar that we provide to you. Hope that you find it useful. There'll be lots of content today and slides available within the next 24 hours, but we have reserved the last 15 minutes of this call today for your questions. So please be thinking through questions that you might have, and Amy Gibson, our Chief Operating Officer, will be joining us to facilitate Q&A. A few other items, as I think many of you are well aware, primary care is a hot topic right now. We've got more than 900 folks who are registered for today's webinar. So we would love to have you get more engaged in our organization, and I'll be talking about that more at the end of the presentation. As I mentioned, we'll have 15 minutes at the end for Q&A, but we do use webinar software for those questions. So please use the drop-down question box on your screen, and then Amy will facilitate that Q&A. And as I mentioned, we're going to record this presentation, and it will be made available in the next 24 hours. So without further ado, I'm often introducing our guest speaker today. That guest speaker is in fact me. I think many of you probably already know a bit about my background. My name is Marci Nielsen. I'm the CEO and President of the Patient-Centered Primary Care Collaborative, and I've been here for now more than 4 years. I have kind of a long history in public policy that relates not only to primary care, but to public health, healthcare delivery, and that is at the state, federal, and even a bit of international work. So with that, welcome again. This year's evidence report is particularly exciting to me in that for the first time, I think really, the work that we've done in examining the scientific evidence around this model or framework of care correlates directly with our public policy agenda. And so it's going to, today, we're going to spend a little bit of time giving you some background, just a single slide on who we are and what we do before we jump into the evidence report. And then we're going to talk about the implications, which I think are particularly important this year when we are so busy implementing payment reform. So who are we? The Patient-Centered Primary Care Collaborative. You've obviously signed up for today's webinar, so you're already familiar with our work. But what we like to sort of embrace in terms of our mission, which is unique, is the special focus we have on trying to unify around this idea of a better health system by better investing in primary care, and that's patient-centered primary care. We have a number of organizations and individuals from the healthcare provider space, but we also have many payers who participate, and we're fortunate to have a growing number of individuals that represent patients and families, caregivers, consumers, and communities. Next slide.
Mine is there.
Okay, and it looks like my whole computer screen is freezing up. So that's part of the problem here. Next slide then, and I'm just going to go to the slides on my machine because, Amanda, I don't think we're in sync any longer. I've got a slide here. We had a Capitol Hill briefing last week hosted by the Primary Care Caucus, and we were very fortunate to have the Honorable Joe Courtney and Honorable David Rouser introducing us as we hosted a conversation about the evidence report and its implications, and I wanted to give a special shout out and thanks to them. Again, the importance this year of linking the evidence to our public policy agenda is very important. Next slide, section 1, a changing policy landscape. I've got our Twitter feed there, PCMH evidence for those of you who are tracking with Twitter. We had a lot to say last week at the Capitol Hill briefing and invite your comments this week as well. Next slide, just outlining who our authors and reviewers were. As you know, we are a not-for-profit voluntary membership organization, so we're very fortunate to have so many people volunteer their time to help ensure that our evidence report is the highest quality that it can be. The authors this year were from the PCPCC, Elizabeth Belt and myself, but Kavita Patel and Len Nichols, both well-known health policy experts, joined us this year as co-authors. And then you'll see the long list of reviewers that were able to help strengthen our report this year, and we'd like to thank all of them. The reviewers themselves looked at an early draft and would just, for the sake of clarity, want you to know they provide input. They do not ultimately sign off on the report. The responsibility for that report is it falls to the authors and to the PCPCC Board of Directors. Next slide, slide number 7. So important to sort of define our terms early on, and I'm going to start with this slide and sort of end talking about definitions and frameworks because it is part of the ongoing challenge in the patient-centered medical home world. We have a framework that I think rallies lots of folks to the cause. As I'd mentioned earlier, having healthcare providers together with payers and patients, families, and caregivers is really part of the strength of this model. I mentioned that the Primary Care Caucus co-hosted our event. Primary care is a bipartisan issue that allows folks who may not see the world the same in lots of other venues to come together around a model of care that is first and foremost patient-centered, person-centered. But there are a number of other important aspects to this model that are defined here: being coordinated, being accessible, comprehensive, thinking about a whole person and their needs and preferences in terms of their health. And then this commitment to quality and safety, maximizing the use of technology. This model, this framework, is fairly broad in nature. How we define the terms become increasingly important during a time of payment reform, and we'll talk about that more in a minute. Slide number 8. So what do we know about this model? Well, we know, even though it's fairly early in its implementation, we've been at this work now for about 10 years at the PCPCC, and we've got patient-centered medical home initiatives happening in almost all 50 states. This is still a fairly early innovation in terms of health systems and health systems innovation. So we hope that you all go to our map. We've got an example of it here, and use our map to see what's happening in your own state and in your own community. Not just what the initiative looks like, whether that's private sector, public sector, but also what the outcomes are. Part of the challenge in an innovation as new as the PCMH is being able to point to the outcomes for whether or not this model actually works. And that's the whole purpose of our evidence report. Next slide. We do have a point of view in this work. And that point of view is that a strong primary care system, a primary care infrastructure is very important to health system transformation that meets the triple aim. In other words, produces better health outcomes for populations, produces a better experience of care for patients and families, but also saves money. This year, and we've done this in past years as well, we focus on cost and utilization of services because that's what policymakers are most concerned about many days of the week as they look at their state budget or their federal budget. But if we aren't also looking at patient outcomes and patient experience of care, we're missing a big part of what this model can deliver. Having said that, very hard to deliver this model of care when you see how little the investment is relative to other industrialized countries in primary care. So my slide that says paying now or paying later is about the 4% of primary care dollars going to patient-centered medical homes and advanced primary care in general. But yet we've got about 55% of all medical office visits being to primary care. So I'm going to come back to this issue again at the end of my presentation, but important to recognize how investment in primary care leads to what many folks and myself agree with is a under-functioning healthcare system. Next slide, slide number 10. So payment reform and Medicare. I keep mentioning that the evidence report this year points us back to public policy. And in this case, we've got commitments from both the administration as well as Congress to thinking far more broadly about the incentives in our health system that lead us to spend too much on care that's of too little value and point us toward this notion of value-based purchasing. This work started some time ago. Health and Human Services Secretary Burwell made an announcement that we were going to shift Medicare fee-for-service over time to this notion of value through alternative payment models. They created what's called the Healthcare Payment Learning and Action Network, and I'm going to say a little bit more about that important initiative. And they've been investing for some time in multi-payer collaboratives at the state and regional level. But Congress has been busy too. They passed legislation referred to as MACRA, the Medicare Access and CHIP Reauthorization Act. They passed that last April against lots of folks' belief that they were going to be able to get bipartisan support, and in fact they achieved significant bipartisan support in both houses for this particular law that got rid of the way we were paying physicians through the sustainable growth rate and began shifting us away from fee-for-service. For those of you who are familiar with the Dr. Who stories, what we know is that the MACRA were actually the bad guys who were kind of terrorizing humans. And so my daughters, who are 14, pointed out that MACRA is actually the bad guy, Mom, not the good guy. And I'm here today to convince you that the MACRA terror can be something that we turn into a MACRA solution for healthcare, but only if we're very, very mindful of how we implement this law in a way that works for practices and works for patients. And I'll be coming back to that as well. Payment reform and the patient-centered medical home. We've been long testing out various models to pay for patient-centered medical home care. And what we found over time, I think anyone who talks to folks who work in a primary care practice know this to be true. Our current fee-for-service system woefully undercompensates the kind of care that patient-centered medical homes can provide, and that's on a number of fronts. That's when it comes to communication, various ways in which we could better support patients in communicating with their primary care practice through asynchronous means, telephone, email, group visits, lots of different things we can do to improve communication that fee-for-service does not compensate for today. care coordination services. We've made some advances there, but not nearly enough to actually use fee-for-service as the long-term sustainable model for how we support patient-centered medical homes. And in this year's analysis of the evidence report, for the first time, we actually look at the payment model that supports each PCMH initiative. And we've got some of those models outlined in the table below. They're included in the evidence report itself. For those of you who haven't downloaded the report, I would encourage you to do so, and I might do a little bit of referencing of what page some of these items can be found on. But what we know is there are lots of different ways to pay for this model of care. No single way at this point in time rises above all others as the best way to pay for patient-centered medical homes. And what we know is we've got lots of testing to do over the course of the next several years, both the initiative that the administration is pushing as we move Medicare away from fee-for-service, as well as MACRA will help us do this, move away from fee-for-service to value more quickly. But again, the pace of that change is incredibly important, and the way in which we're supporting practices is also going to be very important. Those practices today are under-resourced. We're asking them to do more in terms of behavioral health integration, more in terms of care coordination, more in terms of whole person care. So thinking creatively about ways in which we can engage patients and families directly in not only the care, a practice partnership in terms of care delivery, but also how we can engage patients and families in quality improvement. Next slide. So what did the evidence tell us? All that I've provided to you thus far is background, and the evidence is incredibly exciting this year. We've got more studies this year than we've had in any year to date, and the evidence is increasingly positive. So slide number 13 describes the methods that we used to actually do this evaluation. The inclusion criteria, just as in past years, were focused on medical home or patient-centered medical home, or this concept of advanced primary care as the predictor variable. So to make it into our publication, you needed to be overtly looking at whether those terms led to the outcome variable of interest, which were cost and or utilization. If there were other many important publications published this year, but they did not include cost or utilization as an outcome variable, and accordingly they didn't make this report. However, they do get tracked on our map. As we mentioned, this publication came out last week. But the dates that we were looking at in terms of the published reports that were included were between October 2014 and November 2015. This year, 30 total studies, 17 of them peer-reviewed. That's a jump this year. We also had 3 independent evaluations of large federal initiatives that I'm going to speak to in a moment. Slide number 14. Limitations. There are always limitations when you are trying to both pull together scientific studies and whether you're actually conducting the evaluation itself. The limitations of our particular publication, which of course is an aggregation of other studies, is, as I mentioned, there were several important studies that didn't look specifically at cost or utilization, and so they weren't included. There were also several studies that focused on more narrow disease-specific, non-primary care medical homes. Those were not included. And we only included in our tables those measures that reached statistical significance, and when the study authors included data around the level of statistical significance, we include that in our tables as well. But important to recognize, each study varied quite significantly in the kinds of measures it looked at, and that's both predictor as well as outcome measures. And this idea for how we define and measure a patient-centered medical home and the outcomes actually continues to be a challenge, and I'll speak to that more at the end of my presentation. Slide 15. So the results and the trends. What did we learn this year? When you looked across all 30 studies, what we found is that 23 of them were focused on cost. 23 of them include overt measures of cost, and out of those 23 studies, 21 of them found one or more measures of cost reductions. There were 25 out of the 30 studies that looked at utilization of services, and out of those 25, 23 found an improvement in one or more of those utilization measures. So on the whole, in aggregate, pretty impressive numbers this year, and both speak to trends in improvements relative to cost and relative to utilization. Slide number 16 drives that point home by providing some of the details. And I think these the next two slides speak to some of the challenges we have when it comes to measurement that I've now alluded to a couple times. So using measures of utilization first, what are we talking about when we say measures of utilization? Well, we're talking about ways in which we measure emergency departments. And you'll see the study authors use several different kinds of measures. All-cause emergency department visits, ambulatory care sensitive condition visits. In other words, opportunities to keep people out of the emergency department because they could have been managed in an ambulatory care setting. Non-urgent, avoidable, or preventable emergency department visits. Seems that would be the same as ambulatory care sensitive conditions, but not necessarily. Again, I think it's important for folks to see the kinds of different utilization measures that each of these studies analyzed. I don't intend to read to you all of these slides, but want to use this as a means to demonstrate just how diverse the measures are when you look at these 30 studies. If you drill down on a single measure of utilization, emergency department use, what I provide for you in the right-hand column is those studies, just the peer-reviewed, 17 of them, just the peer-reviewed studies that looked at emergency department use in some measure. 13 measures looked at emergency department use reductions. One measure actually found an emergency department use increase. So important to recognize that there are trends here that we can be sort of positive about. We can also point to studies that didn't find improvements, and such is the nature of our scientific inquiry into this model. Again, I list those studies. You can see they range from California to Texas, the Veterans Administration PACT studies. So this is the kind of analysis contained in the tables that are included in the evidence report. If you move to slide 17, I do a similar sort of drill down for you on cost. Out of the 23 studies that measured cost, 21 of them found reductions, but what were the actual measures of cost that the study authors were looking at? Well, on total cost of care, there were a number of different kinds of measures that the authors were looking at. Net or overall costs, a total PMPM, per member per month, per patient per month. You can see there was differentiating in some studies pediatric patients versus adult patients. But then there were a number of other cost measures that study authors looked at. Total spending on prescription drugs, for example, spending on emergency departments, spending for patients that had 2 or more comorbidities, etc. So when you look only at the total cost of care, again, I'm using this more as an illustrative example for folks. If you just look at the total cost of care, what you see there, again, is variation. So there were 10 studies, 10 measures that looked at cost of care savings. One that found cost of care savings, 10 measures. One measure found no net savings. I list out those studies, again, just from the peer-reviewed literature. The state studies themselves tended to have numerous measures of both utilization and cost. And of course, the federal studies, which were independently evaluated, large federal initiatives, had many different measures of both cost and utilization as well. Often we couldn't list all of those measures in our report, and we speak to those limitations. But the peer-reviewed authors often provided us more detailed information on how the particular measure was included in the study, and that's the subset here then I share. Next slide, a final look at the details. So slide number 18 provides you with an example of the Colorado multi-payer PCMH pilot. All 30 studies have this sort of data outlined for you. The location where the initiative actually took place, those cost and utilization measures that I've just provided you a fair amount of detail on, but additional outcomes that relate back to the triple aim when they're included in the study. I also, and I should say Elizabeth, included in the tables, as well as I've mentioned, a description of the payment model. And so all 30 studies provide the data, the details that I've described in each of these tables. But for those folks who are interested in better understanding the study itself, we provide both a reference back to the study, whether that's an industry study, whether that's a state level, federal level, or a peer-reviewed study, as well as a description of the study itself. And for folks who are trying to understand sort of the strength of the scientific analysis in each of these studies, having that description, I think, provides a terrific opportunity for you to quickly ascertain the analytical tools that were used by the study authors. So what does that all mean? Slide number 19. What does it mean to see these trends in terms of utilization and cost improvements? Well, we discussed that on Capitol Hill, and slide number 20 is a picture of the conversation panelists for our Capitol Hill briefing. Dr. Len Nichols, one of the study authors, who is an economist at George Mason University, Chris Kohler, who is the president of the Milbank Memorial Fund, who generously funded the work of our study, and Alyssa Fox, who is the vice president at Blue Cross Blue Shield Association for Federal Affairs. All had a lengthy dialogue amongst themselves and then with the audience about the implications of our study. Slide number 21 points to some of those key findings and the implications. First, the trends were indeed consistently positive, but not unanimously so. We find that if we provide the right care upstream, so more primary care services, we're able to actually change how care is delivered downstream. And thus those consistent reductions that we find in high-cost care, the emergency department use, hospitalizations, etc. The cost savings were evident, but so important to stress that we need to better understand the total cost of care, when we look at this model. Oftentimes, the study doesn't provide us with any details about what it costs to implement a patient-centered medical home. And that cost, especially for small practices, can be quite significant. So if we want to know whether this model works, we've got to start measuring total cost of care, looking at the net savings over time, because implementing this model of care is not a quick or painless endeavor. We are asking practices to literally change their business model, change their workflow, work with patients and families in new and creative ways to change their model of care delivery. Often we're asking them to implement new sorts of health information technology that can be expensive. And to do all this work, again, particularly challenging in small and independent practices, we need to give those practices time, support, and that support isn't just in terms of resources and financing, it's also in terms of knowledge, peer learning. So we've got to start total cost of care if we're serious about assessing whether or not this model can save the overall health system money. And we can see that increasingly we are doing just that, measuring total cost of care, seeing improvements, but the importance of looking at cost savings can't be done in isolation from also looking at whether or not this improves health and improves patient experience of care. Slide number 22, and we spent some time in our report this year assessing, I'd mentioned we see improvements in trends. The trends appear to be pretty consistent over time, but we do note that there are exceptions, and we know that some medical homes, in fact, don't save money, and we need to understand why that is. There was a terrific article this year, several in fact, that pointed to the Pennsylvania experience. Many of you will recall when JAMA about 2 years ago, actually exactly 2 years ago, put an article out, the lead author being Mark Friedberg, that found patient-centered medical home implementation in one area of southeast Pennsylvania, in fact, didn't save money, didn't improve quality, didn't change utilization. Fast forward about a year and a half, and Dr. Friedberg was reporting on the northeast region of Pennsylvania, and in fact finding fairly impressive reductions in utilization, and a few other studies this year also finding cost savings. And so Dr. Friedberg, together with Michael Bailett, really Michael Bailett being one of the evaluators in the Pennsylvania Chronic Care Initiative, wanted to better understand why there were differences. And what they found is that there are nature differences and nurture differences that are very important when you think about implementation of patient-centered medical home. The nature differences often aren't ones that can be changed. They are the practices themselves, the size of the practice, where the practice is located, and the kinds of patients that the practice takes care of. But in terms of nurture, lots of lessons to be learned around quality improvement and how we focus on quality improvement. They found in the southeast region that they were focusing on a single chronic condition versus looking more broadly in the northeast region. And it's important for us to be thinking broadly about quality when we implement this model. When you implement a model quickly without a lot of support, and certainly without a lot of financial support, what we find is there are real challenges. And that was certainly the case between the southeast and northeast regions of Pennsylvania. When we ask practices to focus on recognition or accreditation instead of asking them to focus on transformation, we're often, sadly, asking them to do two different things. That's improving over time, and the accreditors themselves are constantly trying to improve their own test, but at some point over time, the concept of PCMH has become synonymous with recognition itself. And recognition is merely the test. How we recognize a practice is a test of whether they've met patient-centered care delivery. It's important to not get the two things mixed up because the model continues to evolve and the test accordingly needs to evolve. The final thing that I would point to is this notion of payer support and whether or not the payers are giving practices the data they need to be able to provide this kind of care, and that data is provided in kind of a uniform, thoughtful fashion across payers, and the payers themselves are working with practices in a collaborative fashion. So, next slide leads directly, slide number 23, to the next key finding. It's not just payment that matters. It's also alignment of what we ask those practices to be doing in terms of performance, in terms of payer models, and in terms of how we are over time looking at quality, utilization, patient engagement, etc. Are we measuring that and looking at the same kinds of outcomes? Too many patient-centered medical homes, the practices themselves are trying to meet different demands of different payers. So what we find is the best outcomes in this set of 30 studies were actually those where the multi-payer nature, often in a multi-payer collaborative fashion, was working within a state. And I'm going to come back to that in a moment. The longer the practice had been adopting this model of care, the better the outcomes, which I think bodes very well, both for primary care, but also for these integrated models, accountable care organizations. Primary care is the key, but we've got to give primary care practices enough time and support to get us to a place where they're seeing cost savings and health improvements. As I've mentioned earlier, there was no single best model in terms of payment, but every model that did this well was using more than just fee-for-service to support it. Next slide, number 24. We've got alternative payment models. It's sort of the buzzword in Washington, D.C. The patient-centered medical home is a delivery model that's part of this larger framework. And I like this slide so much. It was put together by the Taconic Health Information Network. And it does a nice job of pointing out why having a strong health information technology infrastructure is requisite. You need EHRs and population health management tools together with primary care capacity. So a primary care team that is able to offer this kind of care because they're working together as a team, and that team needs to include the patient and family. They're utilizing care coordination in a serious way, and they're coordinating care for patients and families across the medical neighborhood, but also back to the community. And they're starting to measure both outcomes that can lead to value when they're reporting in a similar manner quality, utilization, patient engagement, and population health. And we're tying, very important here, tying those measures consistently to payment. And that's really the notion of value-based purchasing. If you are only doing delivery reform and you're not tying that delivery reform to payment, this model will not be sustainable. If you are focused solely on payment reforms but aren't focused on delivery reforms that tie to differences in payment, again, not sustainable. So it is the combination of the two that makes this model so powerful. The next slide, number 25, speaks to, I'd mentioned earlier, the Healthcare Payment Learning and Action Network. When Secretary Burwell made her announcement about Medicare payments switching slowly from fee-for-service, actually not so slowly, to value-based purchasing contracts, they also launched this LAN network. And the LAN has recently delivered a final white paper on an alternative payment method framework that we find to be very much in alignment with the PCPCC's views of what payment should be that supports practices. And you'll see the various categories of payment outlined by the LAN. Both Category 3 and Category 4 really building this model on a framework that pays for and provides flexibility to practices to do the kinds of population health management in a practice. That's really the opportunity we have from a public policy perspective. Slide number 26 points us back to the MACRA terror, which, as I've mentioned, doesn't have to just be terror for practices, although you can see how complicated it's going to be to implement MACRA. But MACRA itself provides all kinds of terrific opportunities for primary care practices that want to embrace centered medical homes, for those that want to stay within a fee-for-service world, but also receive incentive payments are linked to pay for performance. Staying within the merit-based incentive payment system will be their opportunity. But for those who are further down the road in terms of implementing the model and are ready to move to advanced alternative payment models, the opportunities for payment incentives that promote this model are even bigger. I mentioned Dr. Kavita Patel was also an author on our report. This is her slide that I have shamelessly stolen but given her credit for at the bottom of the slide. It is important as we come to our final key finding to underscore this notion of multi-payer and multi-payer collaboratives. Two federal initiatives this year were evaluated and are included in our publication. Both of those evaluations were extraordinarily well done and very thoughtful, but very early in terms of looking at the federal initiative itself. And so the results were quite mixed. Promising, but nevertheless mixed. I've mentioned it takes a while to implement this model. Experts estimate anywhere between 18 months and 3 years. And so when you look at any one of the given states that were involved in the multi-payer advanced primary care demonstration, or any of the regions involved in the comprehensive primary care initiative, setting aside for a moment those early federal independent evaluations, what we found is impressive results within the state or the region itself. And I mentioned this in the study, I mentioned this in the slides, because it's easy to disregard early evaluations, much like that early evaluation in Southeast Pennsylvania did. When we give those initiatives time, resources, and support, we continue to see that those are in fact the states and the regions that in fact have the most impressive outcomes, and I list them on slide number 27. My final key finding is one that we're going to be doing a lot of work on in the future. And I'd mentioned early on, we start with the definition of what a patient-centered medical home is. Well, it's really a framework, and that framework is a unifying one that meets the triple aim. But if we're looking to tie very specific payment in terms of these alternative payment models to PCMH itself, we need to better clarify exactly what it is we're talking about, and that definition needs to be one that is in fact feasible, sustainable, and meaningful. Right now, the standards, particularly around PCMH recognition, are lengthy. They are administratively burdensome. They are not simple for the practices that are trying to implement actual transformation. The crosswalk between transformation and recognition isn't as closely linked as it ought to be. I recognize and applaud those accreditors who are doing work to improve that. But it's our job as part of the primary care thought leadership and certainly advocates to suggest that we can do better when it comes to measuring and defining this model. And today, the model itself doesn't have enough relevance to the public because the public doesn't understand what a PCMH is and why it's important. And that leads to the final slides here, speaking to the importance of the Transforming Clinical Practices initiative. A big goal, the largest transformation effort by the federal government, looking at 140,000 clinicians across the U.S., helping them, supporting them, providing that sort of resource and peer support that I've been talking about back to those practices so that they're ready for payment reform when the time comes. The PCPCC was fortunate this year to provide, to be a TCPI grant recipient, and we're focused specifically on patient and practice partnerships and clinic to community linkages to do that work. Slide number 30. And finally, as I mentioned, we're going to be asking for better, more parsimonious, more value-driven definitions of patient-centered medical homes. We're going to be doing that in a number of places this year. I mentioned on slide 31 some of those opportunities, the Safety Net Medical Home Grantee Symposium with Care First, our webinar next month with the National Business Group on Health, looking at specifically how employers and payers can support this model, the National Medical Home Summit, in DC on June 6th and 7th, and then our own 10-year anniversary that we'll be doing with all of our volunteer members and partners on the 9th and 10th. My final slide is a thank you to everybody who engages in our work in supporting primary care. We hope you consider going to our website, downloading the report, signing up for our free monthly newsletter, or even joining us as an executive member. Thank you. I know I've gone a little over, but we started a little behind time. And Amy, I suspect we've got some good questions from the audience.
We do, Marci. Thanks so much. And for those of you who haven't had a chance to put your question in, we don't have a lot of time, but we can follow up with you following our webinar if we don't get to your question. So just a few kind of questions, a little bit high level that you might want to talk a little bit more about in terms of how these resources are getting to primary care. You talk about the cost savings, all of those cost savings being downstream. So if you're a primary care practice that's not affiliated with an ACO, you're not part of a shared savings arrangement, how do those cost savings get back to the practice? And if they're not coming back to the practice, what's the incentive for those clinicians to make the transformation that they need to do to start to be to participate in some of these PCMH programs?
It's a really important question because at this point, we estimate that about 15% of practices have an official designation as a PCMH. That is by some sort of external validator. It's not all national accreditors who do that work. We've got a number of states and health plans who also provide this external sort of stamp of approval. But in lots of places, Amy, and of course it's something we talk about often, we do have practices who are trying to offer this kind of care without those financial incentives. Many of them do it anyway. They look for opportunities, one of which is joining the PCPCC and trying to get access to tools and resources, but they're actually not receiving an increased reimbursement. And all too often, those are small practices, independent practices. That shift, however, is thankfully taking place in both the commercial sector, in some health plans more than others. We see it happening in Medicaid, particularly in some of the managed care plans. We see it now happening in Medicare, not just the fee-for-service, and of course that's what I've been talking about mostly today, but Medicare Advantage plans have long been trying to offer these incentives to practices, and I suspect we're going to see a lot more action in terms of changes in the marketplace as a result of MACRA and as a result of this push by HHS. The most, in my opinion, innovative work has been happening at the state and regional level, and that comes back to the multi-payer collaboratives. So, Amy, if I was a practice that wasn't receiving any incentive today, frankly, I'd send them to our map. I would have them look on their state to see who's doing what kind of payment incentives are actually happening, and reach out to those payers, find out where the opportunities might exist. The other thing I would consider is looking at the world of accountable care and the accountable care organizations that are forming in their region, in their state, that are valuing primary care. We'll have a paper coming out within the next couple of months focused exactly on that topic. High-performing ACOs, high-performing PCMHs. You can't sustain an ACO that's able to improve population health without a primary care strategy. And so there are lots of places, I think, for practices to turn, but the pace of payers getting on board with this model varies significantly by region and marketplace.
Yeah, and like you said, they're continuing to grow, and even through TCPI, providing some additional supports to practices who might not have direct access through the markets that they're in, and the payment systems that they're allowed. So this is kind of a tough question to end with, but maybe just kind of your broad thoughts on this, Marci. We got a couple questions about this. So all of the payment models that were described in the report this year as part of the findings on medical home, and even in MACRA and the other alternative payment models that are being proposed, they still fundamentally keep practices with one foot in fee-for-service and another foot in a more comprehensive payment camp. Is that going to be something that holds back medical home and advancing primary care in the long run? Is there any opportunity that you see down the road that they're going to be addressing that in a more fundamental way, or what are your thoughts just in terms of how we start to make that shift?
Yeah, I think most practices today, as you said, Amy, have a foot in each camp. So there was a terrific article that our colleagues at Harvard put out last year, looking at who's getting paid how, and what you see is most PCMHs are still largely being paid on a fee-for-service chassis, and we're adding additional payments, and those payments could be per member per month. They could be care management fees. We see an increasing shift to population-based payments, but we're still very much having to operate in a fee-for-service world. The challenge is real for practices, and the pace of that shift is really, I almost see sort of two camps forming. There's a camp that says let's be evolutionary about the pace at which practices can shift to these new payment models, and that blended payment is going to be something that practices are going to have to get used to and shift over time. There's another maybe sort of vocal minority that says let's rip the Band-Aid off and let's make this shift faster rather than slower. We've got places like Kaiser Permanente and group health in Seattle. We've got direct primary care practices who are making this shift wholesale. Iora Health. It's not that it can't be done. It's that you've got to have the resources at your disposal to do it. And so I don't have a clear answer one way or the other. But I think practices, as they make the decisions around whether to join into the MIPS program or the alternative payment models, APMs, they're going to have to do this analysis for themselves, and I suspect it will differ significantly, again, by region or marketplace, but also by practice readiness.
Absolutely. And like you said, it's such an exciting time because there really is movement, not only as we're finding through the evidence in regards to what the cost savings are and what the upfront costs to primary care practices are, and then beyond that, what are the costs that we need to move into primary care to sustain that type of care that we're seeing the overall benefit in many ways. So unfortunately, we're at the top of the hour. I want to thank everyone so much for their time and their attention, and as Marci said, for downloading our report and your interest in patient-centered medical home and improving primary care. All of the slides and a recording of this webinar will be available on the PCPCC website by tomorrow afternoon. And again, I apologize if we didn't get to your question. We'll follow up with you at the end of the broadcast. So thanks again, and we look forward to talking with you more in the future about these initiatives. Thanks, everyone.
Thanks, everybody.